All right, so it looks like it's about 2 o'clock, so we'll get started this afternoon. So welcome to the October Neurocritical Care Pharmacy Section Journal Club. My name is Justin Delick, and I'm a neurocritical care pharmacist at Cooper University Hospital in Camden, New Jersey. Today, I will be the primary moderator for the Journal Club presentations. I also wanted to introduce some of my co-moderators, including Esevo Sulejmani, who will be our secondary moderator from the Ohio State University Wexner Medical Center, as well as Kimberly Levisher Franklin from Tufts Medical Center. From a Twitter and X moderation standpoint, you can find posts tagged as hashtag NCSPharmJC today, and Kimberly will be assisting in getting those posts up today. I also wanted to introduce our Journal Club coordinator, Corinne Berger from Nova Southeastern University as well. Today we have two great presenters, both PGY2 critical care residents, including Elise Chan from Brigham and Women's Hospital and Abby Maurer from U of L Health, U of L Hospital. Now, before we get started, just a couple of reminders. If you can please make sure to take a minute to make sure that you are on mute for our presentation so that our presenters are not interrupted. Each presenter will have about 25 minutes for their presentation, and then we will do question and answer session for about 5 minutes after each presentation. During that time, you can unmute yourself to ask the question, or at any time during the presentation, you can post your question in the chat and we'll read that out for our presenters. Otherwise, I wanted to introduce our first presenter, who is Elise Chan, and I will stop sharing and she can begin with our first article on midazolam and ketamine for convulsive status epilepticus in the out-of-hospital setting.
All right, thank you so much for the warm introduction, Justin. Like you said, my name is Elise Chan. I am a PGY2 critical care pharmacy resident at Brigham and Women's Hospital in Boston, Massachusetts. And today I will be happy to lead a discussion on the journal article titled Midazolam and Ketamine for Convulsive Status Epilepticus in the Out-of-Hospital Setting by Zytek and colleagues. Before I jump into the meat of the presentation, just wanted to briefly highlight some common abbreviations that I will be using throughout the remainder of my presentation. So as a bit of brief background, we know that status epilepticus is a disease state that has quite a robust body of literature as well as society guidelines, including but not limited to our gold standard first and second line agents, which is an initial benzodiazepine, which is then followed by a second line anti-seizure medication if resolution is not attained. However, despite these gold standard first and second line agents, we know that up to 50% of patients will not respond and then progress to refractory and sometimes super refractory status. This is in part due to a phenomenon that is colloquially referred to as the kindling effect, in which we see that with increased seizure duration, we see increased difficulty over time in attaining status cessation, as well as an increased anti-seizure medication requirement, with each additional subsequent ASM that's added on being less effective than the last. At the neurotransmitter receptor level, this is because of several conformational changes, including downregulation of inhibitory GABA receptors, as well as the upregulation of glutamatergic or excitatory receptors, such as NMDA and AMPA, leading to renewed interest specifically in ketamine for status epilepticus, given its relatively unique pharmacologic mechanism targeting the NMDA receptors, as opposed to our more traditional agents that target other receptors, or for benzodiazepines targeting our GABA receptors. However, the existing evidence that we have for ketamine for this indication is mostly limited to smaller case studies and case series. And just as a visual representation for some of the neurotransmitter receptor changes, again, as the seizure progresses to status, refractory status, and super refractory status, we see that downregulation of GABA receptors and the upregulation of NMDA and AMPA receptors. So getting into a few of the previous studies we have on ketamine that I mentioned, I'm going to highlight two small case series. The first was a 2020 single center case series by Alka Krum and colleagues that described 68 adult patients with super refractory status. The patients were on a ketamine infusion at an average initial rate of 30 mics per kg per minute, with an average of one other concomitant continuous infusion and having previously received an average of 2 prior ASMs prior to the start of ketamine. A majority of patients were able to attain status cessation, around 60%, and the mortality rate was just under 1/3. The second case series I wanted to highlight was performed by Garcia Ruiz and colleagues in 2024, similarly looking at 58 adult patients with refractory or super refractory status, and very similar ketamine infusion rate at an average rate of 31 mics per kg per minute. In contrast to the previous study, the patients in this series actually were on more prior ASMs with a whopping median of 5 prior to the initiation of ketamine, and were similarly on a median of 1 continuous infusion prior to the start of ketamine. Also very similar endpoints. We see around a 60% rate of status cessation without recurrence in this study as well. And additionally, the authors here tried to look at additional factors that may have influenced the recurrence rate after status cessation was attained, and found that a shorter time from status onset to ketamine start was overall associated with less recurrence, though no difference in recurrence was noted with or without concomitant midazolam. This series also noted a higher mortality rate at just over 50%. Notable limitations that apply to both of these studies, though, again, they're both quite small case series. One took place at a single center and the other at only 2 centers. And because these were retrospective case series, there was no control group. And additionally, in the 2024 case series, as I pointed out, with a median of 5 prior ASMs, there was no standardized treatment protocol. So a lot of heterogeneity between the patients that were included in these studies. Overall, I think that these studies show a lot of promise, but again, there's very limited generalizability, and the usage of ketamine studied here is as a refractory agent when first and second line, and at times even third, fourth, and fifth line agents had already failed. Thus, the authors of this study looked to fill that literature gap and determine the efficacy of adjunct ketamine in achieving cessation of convulsions in treatment of out-of-hospital status. This was a retrospective comparative cohort study, and it took place in a single EMS system. This system had a very unique protocol standardization that took place during the study period, which I will go over on subsequent slides. Patients included had convulsive status epilepticus and were included within a pretty wide 9-year study period between August 1st, 2015 and August 5th, 2024. The authors notably defined convulsive status epilepticus as a convulsive seizure requiring a second dose of medication after the first dose of benzodiazepine. In terms of selection criteria, patients were included if they arrived to the emergency department via ground transport EMS, and if their second medication dose was either a second dose of midazolam or of ketamine. Patients were excluded if they were pregnant, if they had multiple repeat patient encounters, if they arrived via air transport EMS, received dextrose for hypoglycemia, or if there was a lack of documentations about convulsion stopping, as this was a discrete documentation field within the single EMS system. I'll take a little bit of time going over the intervention, as I think it's very relevant in terms of later interpreting the results from this trial. As I mentioned previously, the entire study period spanned over 9 years. However, interestingly, this 9-year period included a time prior to, as well as after, a major protocol change. The major protocol change was mostly related to standardizing the use of ketamine in out-of-hospital status epilepticus. So defining both the dose of ketamine to be used as well as at what point in therapy it should be initiated, which was not standardized prior to June 2017. However, there were additional changes that were part of this protocol update that I also wanted to point out as they could potentially affect the interpretation. So within the entire study period, we have 2 years prior to the standardization, as well as 7 years afterwards. First, I wanted to highlight some of the protocol changes not related to ketamine. So first, we can see that prior to 2017, depending on the route of midazolam, the recommended dose was actually 2.5 milligrams, which could be repeated once for a maximum of 5 milligrams if the midazolam was administered via IV or IO routes. However, after 2017, this was standardized so that regardless of route, the recommended maximum total dose of midazolam was 10 milligrams. We see this similar update in standardization with our pediatric dose recommendation, where we can see prior to 2017, the maximum suggested dose was smaller depending on the route, but was the same at maximum 5 milligrams after 2017. And finally, the main point of the protocol standardization was that prior to 2017, there was no agreed upon dose for ketamine, and additionally, it may have been administered after only a single dose of midazolam. However, after the protocol change, all ketamine was given after 2 doses of midazolam, and additionally, the dose was defined as 100 milligrams for adult patients, which was diluted in 50 mLs of normal saline, or 1 milligram per kilogram in our pediatric patients. The primary endpoint was cessation of convulsions prior to hospital arrival, which was defined as documentation of cessation in a discrete EMS field. Secondary endpoints focused on safety outcomes, including incidents of cardiac arrest as well as endotracheal intubation, which were both defined as occurring during transport after having received status medication. In terms of statistical analysis, the authors performed a multivariable logistic regression with 2 different analyses, an unadjusted as well as an adjusted propensity score matched analysis. To perform the propensity score matching, the authors identified potential covariates that could confound the results, which were identified as having a greater than 0.1 absolute standard difference, which were age, sex, race or ethnicity, duration of out-of-hospital care, IV administration of second dose of midazolam, as well as total dose of midazolam. The authors then used modeled probabilities to perform nearest neighbor one-to-one matching without replacement with an author-defined caliper of 0.2 standard deviations to arrive at our adjusted analysis population. Moving on to the results, 690 patients were identified as having convulsive status epilepticus. Ultimately, 2 patients were excluded as the medical records did not specify if convulsions stopped. So in the final unadjusted analysis, 688 patients were included. This was broken down into 90 patients having received ketamine after either 1 or 2 doses of midazolam, and 598 patients having only received midazolam. Moving to our baseline characteristics, I'll take another moment here just to orient you to the layout, as the layout will be very similar on the subsequent few sets of results. You'll see here in the leftmost 3 columns, we have the unadjusted analysis. So that includes all 688 patients I previously identified in terms of enrollment, while you see in the right-hand 3 columns, the propensity score matched analysis only includes 178 patients that, again, were identified through the propensity score matching that we discussed with the statistics. Overall, between both analyses as well as both groups, both the midazolam only and ketamine groups, that overall the baseline characteristics were very similar, with most patients being white women in their mid-30s. In terms of EMS course, both groups in both analyses had a similar duration of out-of-hospital care of less than 30 minutes, though this was actually identified as being a potential confounder due to the author-defined absolute standard difference cutoff, so it was adjusted for in the propensity score matched analysis. And additionally, interestingly, we see that most patients received their first dose of midazolam intranasally, while the route of the second dose of midazolam where applicable was much more varied. In the unadjusted analysis, significantly more patients in the midazolam-only group received their second dose intravenously. Another thing I wanted to point out is that at first glance, it appears that the total dose of midazolam seems somewhat similar between the 2 groups. However, again, this was actually identified as being a potential confounder for not meeting the statistical cutoff that the authors set. And on further look, we do see that in the midazolam only group, that the total dose of midazolam was actually slightly lower than the ketamine group. So this was ultimately adjusted for in the propensity score matched analysis. Getting to our endpoints, we see that a significantly larger proportion of the ketamine group achieved cessation of convulsions, with 94.4% of the group, compared to only 80.1% of the midazolam-only group. This was true in both of the analyses. However, I did find it interesting that in the adjusted analysis, the confidence interval was actually wider than the confidence interval in the unadjusted analysis. In terms of the additional safety endpoints, there is a similar low event rate of both cardiac arrest and endotracheal intubation throughout the study. Upon subgroup analysis, so dividing patients by age, we see in the adult-only analysis very similar effect size with a significantly increased cessation of convulsions in the ketamine group. However, this was not observed in our pediatric-only analysis, where there's actually no observed difference between the groups. Ultimately, the authors concluded that adjunct ketamine was more effective than midazolam alone at stopping convulsions in out-of-hospital status. All right, now getting on to my critique of the article. I did want to mention that I think there are a lot of strengths with this article, and it mostly lends itself due to the fact that this was able to be performed at a single EMS system with a very unique protocol standardization that occurred all the way back in 2017. So we have a nice body of data over a 7-year time period with this standardization. Because of this protocol, the patients included only received one medication other than ketamine. You'll recall when talking about previous literature, especially with adjunct agents that are not previously described in other landmark trials or the status guidelines, a lot of times there'll be a lot of heterogeneity between these patients with no standardized order of adjunct agents to add on. And additionally, the dose may not be standardized even when studying a single agent. And I think because of the standardization, we know that most patients received ketamine at a dose of 100 milligrams post-protocol change, that we're able to more easily isolate some of the results and attribute them to a specific drug and dose. Additionally, as I kind of alluded to, 94.4% of patients in the ketamine group received a standardized dose, which was the 100 milligrams based on this protocol, which is distinct from the previous studies that I mentioned at the beginning of this presentation, that a lot of those observational case series are, one, mostly describing ketamine use as a continuous infusion, but also since it is a continuous infusion, there's even more heterogeneity and a wider dose range. So really a lot of variability in terms of the dose of ketamine we see used. Additionally, I thought the authors were quite thoughtful with their statistical analysis. I thought they took great care in describing their thorough process in terms of identifying potential confounding covariates, as well as taking steps to adjust for those upon analysis. However, that's not to say that this article went without its limitations. Kind of a double-edged sword. I did mention this is unique. This was a very unique study, only pretty much able to be performed in this single EMS system. However, because it was only performed within a single EMS system, this limits the external validity of the results and our generalizability to other EMS systems in which the practice can vary a lot across the country, depending where you practice, as well as trying to extrapolate to an inpatient setting, which I think is what the audience is probably most interested in, as we're probably, I'm guessing, mostly inpatient ICU pharmacists. So mostly limits the generalizability of the results. Additionally, because this study occurred in the out-of-hospital setting, there is no access to past medical history, which was including the patient's potential anti-seizure medication at home, whether or not they are adherent to those medications, as well as if the patients had past medical history of epilepsy or other seizure disorders, which we know specifically in the status epilepticus disease state. Knowing these things can greatly change how I approach treatment in an inpatient setting, which agents I'm choosing, and what dosage I'm pursuing. Additionally, although the protocol standardization was a great thing to have to standardize and was attributable to a lot of the strengths with this study, I did find a couple inconsistencies as well. Since the study period actually included both time before and after this protocol change, I think it's important to highlight that this does include some patients that were administered ketamine after only a single dose of midazolam rather than 2 post-protocol change. And I think this is important to take into account, as an additional change made after 2017 was a standardization in the dosing of midazolam, which prior to 2017 feasibly could have been a single IV midazolam dose of 2.5 milligrams, which is an underdose per our status epilepticus guidelines. Therefore, if a patient received ketamine and they achieved cessation of convulsions, however, they only received the ketamine after a single IV midazolam dose of 2.5 milligrams, it can be difficult to attribute that effect to the ketamine alone versus the fact that they were not sufficiently dosed with our first-line agent of midazolam. Finally, I did want to touch upon the utilization of endotracheal intubation event rate as a safety endpoint. I do think that this is a fair and reasonable endpoint to be used, especially in the out-of-hospital setting. However, I caution what kind of conclusions we can extrapolate just from this low event rate. It's a little bit unclear to me if the low event rate only signals that ketamine is a good temporizing measure to stabilize a patient before they can then be treated in an in-hospital setting, or if this tells me more and if it actually suggests that ketamine is able to pause the progression of status and prevent patients from progressing to the point that they're no longer able to protect their airway. I don't think that that's something that we can clarify within this particular study, so I would caution the conclusions that we can draw from this. Overall, my take-home summary points are that this is a unique EMS protocol that allowed for this comparative cohort study with great detail paid attention to the statistical analysis, which included but was not limited to the sample size aligning with the a priori determined power calculations, as well as a very thorough propensity score matched analysis. However, I do want to note that overall, I find that there's limited generalizability and interpretation of the results, including some inconsistencies with the protocol used, including whether ketamine was received after only a single or after 2 doses of midazolam, as well as inconsistency in midazolam dosing, which was an underdose prior to 2017. So ultimately, I find that the results are hypothesis generating, not yet enough data to change my clinical practice or to promote the use of ketamine earlier on in status treatment. In terms of future directions, one final note that I'll have as an inpatient ICU pharmacist, I do anticipate that depending on which institution you practice in, there may be some limited operational applicability of ketamine compared to our existing second-line status medications. Depending where you practice, you may have to first dilute ketamine similarly to this protocol in saline, or your institution may actually allow for an undiluted push. However, depending on, I know at my institution, there are actually several restrictions on the use of ketamine. So if you are practicing at an institution similarly to mine, it may actually be easier to use our existing second-line medications, even with more efficacy data for ketamine. However, nonetheless, I'm still excited to see some next steps, including I would love to see a randomized control trial that compares in-hospital ketamine with our standard of care second-line status medications. And before I hand things over to the audience for any comments and questions, I did want to acknowledge and thank Mike Shantz for precepting this journal club, as well as my PGY2 critical care pharmacy leadership for supporting me throughout this process. And that's all I had. Thank you so much, everyone, for listening and for your time today.
Excellent. Thank you, Dr. Chan, for your presentation. We now have a few minutes for questions. So again, if anyone has any questions, you're welcome to unmute or to type it in the chat. And I can kind of get started as we move into this section. So as you were alluding to at the end, we now definitely have some more data on some of our other second-line anti-seizure medications and either IV push or rapid infusion. Now this study had kind of included patients going way back to 2015 to 2017. But if we were to kind of do this study now, do you feel like there might be any benefits to include other second-line anti-seizure meds in this out-of-hospital setting, after midazolam, or do you think that ketamine, is kind of an ideal medication for this kind of population in this setting?
Yeah, I think particularly in the setting of the out of hospital, I'm not an expert by any means in this setting, but I think they're more resource limited with what you can bring on the actual EMS vehicle. So I think ketamine can be a good choice and probably why it was targeted as an agent in this particular EMS system, because it's probably already on board versus some of these other second line agents that were established in the ESET trial, for example. They may not carry these agents necessarily on every single EMS vehicle. So that's why I would really love to see in terms of future directions, depending on both the out-of-hospital and in-hospital setting, I'd love to see it compared to those previously established second-line agents in our landmark trial. So I'd love to see it head-to-head against, for example, levetiracetam or valproic acid. I think also, maybe this is also the intention with your question, I think there's a lot of emerging interest as well as potential literature, also limited to kind of case series for lacosamide and perhaps a couple other well-tolerated second-line agents. So I think it'd be interesting to kind of include as able some of these agents of interest all together in a head-to-head trial. But I'm not sure the feasibility necessarily, but I'd love to see it.
Absolutely. Yeah, I think that that's going to be really interesting. And definitely ketamine is an interesting agent for a number of reasons, which we'll, again, talk about in our next presentation as well. I had recently heard that some of our EMS providers were actually going to start with a protocol to carry some levetiracetam on board for some of our patients who are coming to our hospital. So I'm excited to see how that goes as well. But great job, answering that question. Any other questions from the audience at this time?
I had one question. Hi, Elise. My name's Andy. I'm the neuro ICU pharmacist down the street, so I'm at MGH. So I guess first, you're going to get your wish. So the KeySet trial should start enrollment soon, which is going to be randomizing patients to ketamine plus levetiracetam or levetiracetam alone. So you'll have your answer probably in 10 years. But my question for you is I'm curious if you're, say ketamine rolls out in pre-hospital setting, would you change your management if a patient came to the ED who is still in status despite having gotten a dose of ketamine?
Yeah, I think that's a complex question. I think like the cop-out answer is, of course, it depends from patient to patient. I think once I'm in the in-hospital setting, I have the privilege of being able to look up the chart and maybe like get more collateral on the patient's past medical history, which I identified as a potential limitation in the out-of-hospital setting. So potentially it could change depending on if I see that the patient was like non-adherent to some of their anti-seizure medications at home. Perhaps I would switch to those agents as well. But to your point, I think without this collateral information, say this happened in a patient without previous history, if I see that they've responded to the ketamine, let's say it was the 100 milligrams that we saw in this protocol, and perhaps it worked, and then maybe there was like a recurrence, or maybe there's still some, we haven't achieved like burst suppression and we need to, and we're in like refractory or super refractory status, maybe that suggests that maybe we should go to like a continuous ketamine infusion. We can kind of treat that first dose almost like a bolus. That's something that I didn't mention, but can change from like institution to institution, that some institutions may not actually use IV push or IV bolus ketamine for status. They might use like a bolus from infusion to kind of start out that continuous infusion. So I could see that as a potential treatment pathway that I might pursue if I know that they did respond to the ketamine, but actually now we've recurred now that the effects of that has worn off.
Yeah, awesome. Thank you so much. Yeah, I mean, we're a very ketamine happy hospital, so I think we were starting to see it move earlier and earlier in management. So I think those thoughts are great. That's kind of how it fits, and hopefully we get some more data from KeySat as well as some other observational studies as to where it fits best into therapy.
All right,
Hey,
excellent.
Elise. Oh,
Oh, there you go.
okay. Just had one more question to fill out the last 3 minutes. My name's Asilva. I'm from Ohio State. Great job on the presentation, by the way, and I really liked how you summed up the limitations as well. You talked about the dosing of midazolam in the out-of-hospital setting, and I think one of the more interesting things or thoughts that I had when I was reading this trial was that the dosing is just way under what we would do here at Ohio State, and I don't know what you guys do there as well. But I think for me, that was a little more difficult to see whether this was like a positive or a negative trial, positive for ketamine or negative for midazolam. But I kind of wanted to hear your thoughts on if you were to do this trial again, like out of hospital. I know you were talking about in hospital as well, but out of hospital, would you kind of just try to rerun it in a more modern setting, or would you actually like change the dosing of midazolam or standardize the dosing of ketamine or things like that? Or if someone came in on a different dose of midazolam, like how would that change your practice?
Yeah, I think that that's definitely like I think one of the bigger limitations, and I had like a similar thought when I was reading this trial, that ideally if I were to rerun this trial, that we would have like a standardized dose of both the midazolam and the ketamine. So I thought it was interesting that they included time where neither of those things were standardized within the study population, because I agree that that would lead the authors, if I was running this trial, I think that would put me in like a sticky situation of, do I include these patients that meet the other selection criteria and kind of put them in another like subgroup analysis where I don't think that the midazolam was adequately dosed, or do I exclude them altogether because they didn't meet our guideline directed? I'm sure your institution follows something similar at like 0.2 mg per kg for a maximum of 10 milligrams, versus we kind of discussed prior to 2017, 2.5 milligrams is like a 75% underdose. So I think ideally I would want to standardize both, because I totally agree that it's really hard to isolate the results here. But because this happened in the past and also in an out-of-hospital setting, it may be difficult to control for this. And I don't know if excluding that many patients would lead to a sample size that didn't meet the previous power calculation. So I think in an ideal world, I definitely agree and would standardize these things. But in the real world, I think it's a little bit difficult to say, a little more nuanced, whether we include or put them in a different subgroup analysis if they were underdosed.
Yeah, great job. Totally agree. I mean, that's the problem with retrospective trials too, right? And single spreader, all our resident projects, you know. But if someone came in on like midazolam 2.5 or something, we wouldn't, for at least for me, we wouldn't like jump to another drug. We'd probably be like, okay, well, let's finish this dose and then see how they respond to an actual dose, like you said. So completely understand. Great job.
All right, excellent job, Dr. Chan. Thank you very much.
Thank you.
So we'll move on to our next presentation. So Dr. Abby Maurer is going to be presenting on the effect of ketamine analgo sedation on neurological outcome in patients with severe traumatic brain injury, a randomized controlled pilot study. So Dr. Maurer, you can share your screen whenever you are ready.
All right. Can you guys see the screen?
Yes.
Okay, perfect. All right. Hi, guys. My name's Abby. I am the PGY2 critical care resident at U of L Health in Louisville, Kentucky. And today we're going to be talking about ketamine analogous sedation and neurological outcomes in patients with severe TBI. So just some overview and objectives to briefly review the pathophysiology of traumatic brain injuries, analyze a new trial investigating the use of ketamine in traumatic brain injury patients, as well as discuss future direction for analogous sedation research in traumatic brain injuries. So just kind of going over the basics of TBIs, which I'm sure we're all familiar with. The primary injury is the mechanical forces that impact the brain tissue and trigger then the secondary injury. And the secondary injury involves the dysautoregulation of vasculature and the blood-brain barrier disruption. It can lead to increased ICP and then decreased cerebral perfusion pressure, CPP. Sympathetic activation can lead to organ damage, as well as the triggering of immune response, apoptosis, neurotransmitter release, mitochondrial dysfunction, and immune or inflammatory responses. So in these patients, we really want to look at normotension to maintain perfusion without causing an adverse reaction, such as hyperemia, because this can increase ICP and cause permanent brain damage. Going to the Brain Trauma Foundation guidelines, propofol is the preferred sedative of choice in patients with severe TBI, mainly because we have the most data surrounding this. And the 2018 PADIS guidelines mention ketamine as an adjunct to opioids, and they provide a little bit of guidance on how to dose this. So 0.5 mg per kg IV push, as then continued with 1 to 2 mics per kg per minute of an infusion. Ketamine in and of itself is an NMDA or an N-methyl D aspartate receptor antagonist that mainly affects the central nervous system. It also increases catecholamine reuptake, which thereby we see the effects of increased blood pressure. And as Dr. Chan already talked about ketamine a lot earlier, we won't belabor it, but it has a pretty fast onset of about 60 seconds or less and a half-life at about 10 to 15 minutes. So kind of how did we get here? There were a lot of previous trials that raised a concern for increased ICP or intracranial pressure in patients who received ketamine. So a lot of these took place in the 70s, and we'll just go over a few of them briefly. So in 1972, there was a case report by White and colleagues, and there was one pediatric patient who had a VP shunt placed for obstructive hydrocephalus, and he just received one push of ketamine of 60 milligrams. They noted an increase in ICP that was pretty dramatic. It was over 4-fold, and there was an increased respiratory rate as well as increased systemic blood pressure, which we can still see today, and sometimes the reason why we like ketamine. Additionally, there was another study in 1972 that had 7 patients. It was a case report retrospective of 1 adult patient, but it involved 6 pediatric patients, so a little bit of a different patient population who had hydrocephalus who were undergoing either a VP shunt or a ventricular venous shunt insertion. They used ketamine as well as atropine in these patients, and the dosing is listed there. They saw patients had a decreased respiratory rate with increased tidal volume, and 6 patients experienced increased cerebrospinal fluid pressure for an average of about 7.5 minutes, but no patients experienced apnea or hypoxemia. So they concluded from this that the use of ketamine can be closely watched by looking at the cerebrospinal fluid pressure. And then the same year, there were a lot of ketamine studies. This was the last one that was a prospective observational study. It looked at 7 patients with acute intracranial pathology, more generalized, and they used dosings of either 2 mg per kg IV or 4 mg per kg IM. And their primary outcome was the change in intracranial pressure after the administration of ketamine. In the patients who had normal CSF dynamics to begin with, they saw an increase in ICP of under 10. But in patients who had abnormal CSF dynamics, the average ICP rose from 13 to 63. And of these 7 patients, 2 of the 7 patients were given ketamine multiple times. And each of these times that they were given ketamine, they saw an increase in ICP. So kind of what have we gotten from there? There's been ketamine studies here and there, but in 2022, there was another study that came out by Dengler and colleagues that was a retrospective observational single center study that looked at patients with severe TBI, and they had an ICP monitor, an EVD, and they had a measured ICP of over 20 to begin with. They were given 2 milligrams per kilogram IV bolus of ketamine, and their primary outcome was change in ICP and cerebral perfusion pressure, CPP, following ketamine administration. What they found was that when ketamine was administered, they saw a decrease in ICP by 3.5 millimeters of mercury, which was a statistically significant value from their baseline to their end ICP, as well as an increase in their CPP by about 2 points. So both of these were statistically significant values that kind of got the wheels turning on to what does the old literature say versus if we do a study now, what are we going to find? This was a study that solely looked at pediatrics, so looking at a little bit of a different patient population, but it was a prospective single center open control randomized clinical trial of 112 patients. So it had a pretty good enrollment with elevated ICPs over 18 that were resistant to first tier therapies. So they had 2 groups in this. They had one group and that used ketamine to prevent ICP increase, and the other group used ketamine, same dosing, but used to decrease ICP that was already elevated. Their primary outcome was change in ICP or CPP for 10 minutes following ketamine administration. So if you think back to how long the duration of action is, with 10 to 15 minutes, it's kind of hitting that range at that 10-minute point. So when they compared the groups, group 1 had decreased ICP within 2 minutes, and it was a statistically significant difference from baseline to the change at 2 minutes, and overall had about a 20% decrease in ICP throughout the time. Group 2 had also a decrease in ICP that was statistically significant. You can see they both started a little bit different, but right around 25, 26 millimeters of mercury and ended up around 18, a little bit less. But they found that the decrease in ICP was around 33%. And then the final study we'll look at prior to going into our study is ketamine use during suctioning. So this was an international prospective single center study that looked at patients with severe traumatic brain injuries that had ICP monitors in place, and they had a control group as well as an intervention group. The control group received propofol and remifentanil, versus the intervention group had propofol, remifentanil, as well as ketamine for 10 minutes. So their goal was to look at changes in ICP after administration of ketamine and 10 minutes following the endotracheal suctioning. So comparing ICP prior to the ketamine administration to following the administration, the ICP was normal in the intervention group prior to suctioning. So after they received the ketamine, from baseline to after ketamine, but not before suction, or before suctioning, not after suctioning, it was normal and there was no statistically significant difference between these values. However, the ICP did increase after endotracheal suctioning, but that begs the question as to if this was due to the cough, the suctioning itself, or the agent. So that kind of leads us into our study today from Berman and colleagues. So this was a prospective randomized controlled pilot trial that was a single center in India. It took place over about a year and a half of September 2018 to March of 2020. And their purpose of this study was to evaluate the effects of ketamine analogous sedation on the 3-month outcomes for patients that had severe traumatic brain injuries. They included patients with a baseline GCS of 3 to 8 that were 18 to 49. They had to be mechanically ventilated, and had to have an intracranial monitor in place. They excluded any patients that had major systemic diseases, the American Society of Anesthesiology or ASA class 3 or higher, multiple life-threatening injuries, glaucoma, physical history of psychiatric illness or epilepsy, as well as if there was no consent on file. So as you can see by this inclusion and exclusion criteria prior to even the baseline characteristics, this was a pretty healthy group to begin with. So just keeping that in mind. They standardized as much as they could. So the patients had to have arterial lines, central lines, retrograde jugular venous catheters, as well as interparenchymal ICP microsensors. Their goals of the study were to maintain arterial CO2, partial pressures from 35 to 40, as well as normothermia, systolic blood pressures above 110, and normal glycemia. So kind of what we aim for in a lot of our TBI patients at baseline. Their groups were controlled as well as experimental. So the experimental group had fentanyl at 1 mic per kg per hour, midazolam, and it was a very large dosing range. So anywhere from 0.05 to 1 mg per kg per hour. And then ketamine, patients received a 300 milligram bolus and then were put on a continuous infusion of 3 milligrams per kilogram per hour. The control group had everything except the ketamine. So they had fentanyl at 1 mic per kg per hour and midazolam at 0.05 to 1 milligram per kilogram per hour. Instead of using the ketamine, they used sodium chloride or normal saline infusion. Their primary outcome was the GOSE or the Glasgow Outcome Scale Extended at 3 months. So just kind of a brief overview of what does that look like. There's different scores from 1 to 8 on the GOSE. So 1 going from death and then 8 going all the way to return to normal life, fully return to life prior to injury, and had a very good recovery. So this is how they graded the patients. Additionally, in their secondary outcomes, they included intracranial dynamics in patients with severe traumatic brain injuries, as well as systemic pressure dynamics in patients with severe TBI. As far as blinding and randomization went, they had a very interesting setup. So patients and investigators themselves were blinded, but there was a charge nurse on the unit that were all oriented to this study. And depending on their shift, when patients were enrolled, they were unblinded from what group they were going to be in. And they actually mixed the medications in the units. So the charge nurse did everything up there and then gave them to nurses to administer, but nurses were not aware as to which arm the patients were randomized to. And all of these patients were randomized via block randomization. As far as statistics go, they used independent t-tests to look at their continuous variables that had normal distribution, and Wilcoxon rank sum tests to look at variables with abnormal distribution. So what did they find? This was their enrollment. They had 73 patients that they initially screened and excluded 13, either due to not meeting criteria, declined to participate, or other reasons that were not described more. So in total, 60 were randomized, and that was 30 in each arm. So 30 received the ketamine, as well as 30 did not. No patients were lost to follow-up, and all 60 patients were analyzed. So out of baseline characteristics, the average age was right around 31 or 30 between the groups. So right in between that 18 to 49-year-olds. Majority of the patients were male, but just kind of looking at their baseline map and ICP, these patients had an average map of around 77 and 74, but there's no statistically significant difference between groups. Average ICP was 12.8 versus 13.9, and their baseline CPP was 64 versus around 59, but none of these were statistically significant. As far as their injuries go, just wanted to highlight the intraventricular hematoma and subarachnoid hemorrhage. There were no statistically significant differences between any of the type of intracranial injuries that these patients experienced. Most of the most common type of injury was the subdural hematoma, with 33% in the group that received ketamine and 26% in the group that was randomized to the control. So that's what those were. As far as primary outcomes go, so the average GCS at discharge was around 8.8 in the ketamine group and 8.5 in the control group. However, there was no statistically significant difference. The GOSC at discharge was 5.2 in the ketamine group compared to 5.03 in the control group. And then at 3 months, these patients did not have a statistically significant difference. It's 5.1 versus 5, essentially. They also broke these up into the favorable outcomes versus non-favorable outcomes. So scores 5 through 8 were noted as the favorable outcomes. This was 60% in the ketamine group compared to 73% in the control group. 10% of patients who received ketamine died in the hospital, and 13% in the control group died. So kind of highlighting what we were looking at for the drugs as well as the other outcomes. These patients on average in the ketamine group received 4,100 milligrams of ketamine, and in the fentanyl group received an average of 1,352 in the ketamine group, and in the control group around 1,600. This was statistically significant because the group that did not receive ketamine received more fentanyl, as well as the midazolam. More patients, the patients in the control group received more Versed or midazolam than the ketamine group. The average duration of the infusion was about 24-25 hours in both of the groups. So that was around 4,100 milligrams in 25 hours. I also wanted to point out the vasopressor use in these patients because we think of ketamine often being great for patients who are not catecholamine depleted in that they can raise blood pressure. So more patients in the control group had to receive vasopressors than the patients in the ketamine group, which is something we would expect, but this was a statistically significant difference. As far as other secondary outcomes go, so the mean value of the heart rate, the purple in this is the representation of a statistically significant difference. So starting at about 2 hours, there was a difference in heart rate in that the ketamine group had a significantly higher heart rate than those who did not receive ketamine. This is the average MAP of the patient. So from about 4 to 6 hours, these patients that received ketamine also had a higher MAP than the patients who did not. It was not statistically significant at the beginning, but it became statistically significant just for those 2 hours. This is going over CPP, which also was statistically significant in that it was higher in those who received ketamine at 4 and 6 hours, which we would expect that if the MAP went up, that most likely their CPP was going to go up unless there was a great change in their ICP. As well as, here's the ICP. So the patients in the control group actually had a higher ICP at 4 to 6 hours than those in the ketamine group. So what did the authors conclude from this? Their conclusion was that there was no improvement in neurological outcomes in patients who received ketamine. However, their big caveat was that there were no negative effects in the patients who received ketamine. So going into my assessment and conclusion, strengths of this trial was that it was a prospective, randomized, and blinded trial, always something that we love to see in trials. And there was frequent and appropriate monitoring in these patients. However, limitations, it was a single center and small sample size that can limit generalizability to other centers. Their primary outcome was GOSC, which was a little interesting, just comparing this to other studies. It's not something that we've commonly looked at. Patients could receive up to a very high dose of midazolam, and they did receive a lot of midazolam. This is definitely a key limitation to the study, as that might mask some of the effects of rises in ICP, but both of the groups received high dose midazolam. The patients that received ketamine in the experimental group also had a high dose of ketamine given as their bolus. Typically at our institution, we give around 1 mg per kg for sedation to 1.2 mg per kg. And these patients received up to 300 milligram bolus of ketamine. So that would also be something to keep in mind when thinking about applicability. As well as all these patients received midazolam, all these patients received fentanyl, so that could muddy the waters as well. ICP monitoring only continued for 24 hours, so I really would have liked to see what these patients' ICP might have done in 48 or 72 hours, and as well as the generalizability to all TBI patients. They did not go into a lot of description besides their baseline traumatic brain injury as to who this might apply to. Would we apply this to all of our patients? So my conclusions from this study was that the reputation of ketamine increasing ICP mainly stems from case reports that were a while ago, around 40 years ago, and a lot of those were published in the 70s. The high use of the high dose midazolam was definitely a confounding variable to analyzing the effects of ketamine on ICP, and ketamine was not associated with increased adverse events, which is great. Other studies have shown that ketamine isn't associated with increases in ICP, so this study kind of went along with what we have seen recently in literature of the effects of ketamine on ICP, and ketamine may be safe to use in patients who are at risk for elevated ICP. However, given the limitations of this study, I don't think that you can quite make the conclusion that ketamine should be used in all patients with traumatic brain injuries to decrease ICP. Of note, just to keep for our applicability at our institution, we don't typically use ketamine drips. So I think if there was a little bit more robust data, this might be something that we could consider for a lot of our TBI patients. But I think we would need to see some more data first. So future direction and what would I like to see? Assessing patients for longer than 24 hours on their ICP monitoring, I think would be very beneficial. Comparing ICP during the ketamine infusion versus after they stopped the drip, and how much does that change? And did the ketamine actually decrease their ICP? Was it limited by other uses of medications like midazolam? Decreasing the initial ketamine bolus to be something we might follow a little bit more in clinical practice, as well as comparing the effects of ketamine on ICP to midazolam or propofol. I would love to see a head-to-head trial of ketamine versus Versed on ICP, as well as there is a study in the works, the brain injury and ketamine study, that's kind of looking at this as well to see how ketamine affects ICP. I saw that it was started, so I'm really looking forward to the results of that. With that, I can take any questions that anyone might have.
Great. Thank you again, Dr. Maurer, for your great presentation. So I can kick off the questions here. And again, if anybody else has any, feel free to type them in the chat. So for this study, in terms of other therapies for ICP management, namely things like our hyperosmolar therapies, was this standardized or even reported in the study? And do you think that that could have had any impact on some of the predominantly, I guess, more so the secondary results or the secondary outcome results that we've seen, but even the primary?
Yeah, so I don't think this was a standardized portion of the study. And I think that definitely could have affected what they saw in the results. I think that also might be something that they could implement in future studies as to if they want to standardize that. And especially since it was at one institution, certain providers might have a preference versus hypertonic saline versus mannitol, and that might affect their outcomes.
Yeah, I think that anytime, you know, even though this was a pilot study, right, and we only had a certain number of patients, you know, maybe hard to see a significant difference in our primary outcome, but certainly interesting to see, you know, our effects on ICP. So as a, you know, a reader for a study like this, I would certainly be interested in what kind of other, you know, ICP management strategies were used along in that time. Any other questions from the audience?
Hey, it's me again from Ohio State. Once again, great job on your presentation too. I kind of wanted to ask a little bit about the vasopressor piece and the hypotension piece. So the authors talked a lot about other sedatives causing hypotension and ketamine maybe being a little more blood pressure sparing, I guess might be a word that I just made up. But what role do you think ketamine might have in these patients? I know you said this was a pilot study, single center, different country, but I guess for you, if you had a patient with TBI, when would you think about using ketamine if your institution actually used it?
Yeah. So since we don't use it, we don't see it as much, but we do use it for patients, especially that are like coming through the emergency department if we do need to intubate them. So that is something to keep in mind, like when they're super hypotensive, it might be useful to use ketamine as an induction agent, as what I've seen so far in patients, as well as those who might require many vasopressors to sustain their blood pressure. It might be something to consider for an algo sedation in this patient population that are experiencing TBIs. If you know that they haven't been down for a long time or aren't catecholamine depleted, then you might not have the same effects if they are catecholamine depleted.
Yeah, I 100% agree. And I do think that that was kind of one of my gripes with this paper, is that they didn't really talk about that piece a lot. They talked about it a lot in the intro, but then they didn't really mention like when the vasopressors were started, what types were started, or how long they were on, or things like that for a real like comparison of that piece as well for the safety. Yeah, great job.
Great. And any other questions? I don't see any in the chat as far as I can see. All right. Well, thank you again, Dr. Maurer, and to both of our residents. Thank you again for everybody for joining our journal club today, and hope you have a great weekend. If you're looking on Twitter or X, again, you can follow that hashtag NCS. NCS Farm JC. Sorry. Thank you.